thumb. Okay, now we can make this real complicated and do a whole bunch of funky stuff here, but let's be realistic with this, right? Most of the issues that we're going to deal with the thumb are going to be these opposition reposition problems, right? Most of these are going to be solved by correcting the trapezium on trapezoid, right? Now, as we're looking at this, we dealt with these sagittal plane joints, right? This joint between the trapezium and the trapezoid is an oblique joint, right? It's going to be off at almost about a 45-degree angle from the other joints, right? If this is kind of the vertical, looking at it from that perspective, this is off at about a 45-degree change, okay? So what we want to test for with this, right, is we want to fix the trapezoid against the capitate, just like this, right? And then we want to assess palmar glide. Now this is going to be a more curved joint, right? This is going to have much more of a curvature to it. So there's more of a swing to this glide. Palmar glide. She's actually a little stiff in the dorsal glide there. Yep. Okay. So that's really it when it comes to that joint. Okay. So there are two techniques if we happen to run into a capsular pattern, again, same as what we've been saying all weekend. No significant difference between what we just were showing you and the actual treatment technique. Okay. In her case, this thing feels pretty jammed up to me. Okay. So how would we treat that? Well, I need to take that trapezium and bring it into a reposition moment. Okay, opposition is coming across, reposition is coming back out of that. So we would turn the hand over. I'm going to take this hand and I'm going to grasp the trapezoid with basically the hook of my index of my middle finger there. Hold that against the capitate. We're going to set this down on the table. I'm going to come over, I'm going to get the thenar eminence of this hand over the trapezium, and then I'm gonna have to take up some slack in the bed here, but there we go, and thrust down, okay, along the plane of the joint. Okay, and then we're gonna come back and we're gonna retest, and we're gonna look pretty good. Okay, nothing terribly complicated there, right? If I had to go in the opposite direction, again, I'm going to take the trapezoid right here. I'm going to pull that against the capitate. I'm going to come over the dorsal aspect of the trapezium. Now, I'm not going to do this because I just pulled her out of this position, but we would take up the slack and push down, again, right through that left hand. All right. This is very similar to a squeeze manipulation, right, where we would actually come over the dorsal surfaces of both and squeeze them together. Gail once showed me a technique. It's almost like a breaking bread manipulation for opposition. So we would go here, here, and then it's this sort of motion, trying to pull my thumbs apart. So here, whip like so. Okay. And then we could relatively do a very similar thing. Fix the palmar side of the trapezium, fix the trapezoid against the capitate again, and whip that down, pull that back into reposition, like so. That would probably work as well. It's a more curved surface, again, remember that, so we have to make sure to change our vector into more of this arcing movement as opposed to a straight planar movement. But to be honest, I prefer these ones, here. Okay, outside of that, the most common issue that we're going to have here is an arthrosis of the CMC joint. So this is between the first metacarpal and the trapezium. Capsular pattern is going to be a loss of extension and abduction. Okay, now what happens with this is we're going to need to fix the trapezium, right? So what I typically will do is I'll just grasp it with kind of a key grip, like so. For extension, remember the joint glide changes. This is the female component. We're just going to work into an extension moment. If we're dealing with a abduction moment, we're going to take it into abduction, but now the glide has to be opposite. Right? So we'll take it into the opposite position, glide it toward me.
Are you applying any compression or traction on that? Or just...
No, I mean, you could apply some compression if you wanted to help with the joint health, but I'm not typically worried about that because it's a saddle joint. It's a little harder to get good compression and maintain the glide. What if you wanted to do that, probably the best option would be take yourself to the barrier first, then compress, and then glide, right? Rather than trying to compress and glide at the same time. Get to the barrier first. Okay. Now the last little thing would be for either the interphalangeal or the MCP joints. Capsular pattern here, this is going to be the most common problem that you have is some sort of traumatic arthritis, like a jammed finger sort of thing. Is going to be greater limitation of flexion than extension, right? These are modified cellar joints, so they have the 1 degree of freedom, flexion and extension. There's a conjunct rotation available. Typically it's extension with external rotation and flexion with internal rotation, although functionally that could be challenged based on the position that the hand gets into when you make a fist. But to be honest, it's easier to do a dorsal glide with external rotation, do a dorsal glide with internal rotation, do a palmar glide with internal rotation, and a palmar glide with external rotation to make sure you get the entire joint capsule. Okay, and then that can be applied to any of the interphalangeal joints, any of the MCP joints, or even the thumb. Okay. I think I mentioned this earlier in the weekend, but one of the most frustrating things as a physical therapist is somebody that has had a finger fracture, an intra-articular finger fracture that gets into the joint. It's so frustrating because you'll always get these patients from the doctor saying we need mobilization, we need to get this range of motion back. It's like 8 weeks after the injury, and there's just nothing. It's a complete and utter bony end feel because the bony callus inside the joint is still there. We've got to give it time to actually let that callus, that woven bone, actually be reabsorbed by the joint, and then at that point we can actually start to regain range of motion. So realistically, in those scenarios, we're working on just maintaining the motion that we have, but the odds of us gaining substantially until that callus is reabsorbed is just not real great. So I always want to just make sure that the patient understands when we're looking at something like that, like, look, we're running into bone here. This is just residual from the fracture. It'll eventually heal itself up. But until that happens, you're going to have a stiff finger. All right, we'll get it going, but we don't need to see it 3 times a week to work to hammer away at this thing because it's just not going to change much. And so maybe we check in with that person every couple of weeks just to, keep them engaged. And then once we start seeing better joint glide, better end feel out of it, then we can really get after the soft tissue stuff.
Is there a typical time frame for the reabsorption?
It's going to usually depend on the severity of the fracture, right? So a displaced fracture is going to obviously have a longer time frame because they probably needed something to, set that anyway. But no, I would say you're probably looking at beyond 12 weeks before you're going to see that start to reabsorb. I've had patients come in, 4 months after the fact, and it still feels like running into a brick wall. So again, you have to take into consideration the patient's overall health, right? Somebody that's diabetic, they're going to have some of that microvascular damage into the hands and such. They're just not going to heal as well because they're not going to have the blood supply to do so. Somebody that's a smoker, Somebody that's that's significantly overweight, has other cardiovascular issues, things like that, they're gonna delay the healing process. Somebody that's young, fit, non-smoker, etc., they're gonna have a much easier time of getting stuff healed up quickly. So, anyway, that's one of the frustrations that you run into in the hand a lot as a physical therapist. The physician will look at it on an X-ray and say, well, it's healed, it's stable. But the difference between healed and stable are two different things. Like, it's not going to fracture again if you move it, but it's also not healed. Healed means it's done, and we know, scientifically speaking, that bone repair goes on and off for about 2 years after the fact. So getting to that point where you're saying, well, it's healed, like, yeah, it's not broken anymore, but it's not healed. So I think that's just something we have to communicate to the patient, make sure that they're aware that this is more of a process than, 2 months from now you'll be back to normal. And not quite.